So today in our Journal Club, we have our two moderators, Dr. Rajesh Pramanik, who is a professor and HOD, head of department at IPG, MER and SSKM Hospital, Kolkata. He is in charge of PDCC pain management and neuro rehabilitation and in charge of sports medicine and rehabilitation at IPG, MER and SSKM Hospital, Kolkata. He is also an ex-editor at the Indian Journal of PMR. He has authored multiple papers and he's a examiner to at various examination centers. So today we welcome Dr. Rajesh Pramanik sir. Thank you for being present here as a moderator. So and our second moderator is Dr. Shrijith sir. As we all know, he's a professor and head of department at the Department of PMR, Government Medical College, Kozhikode. He has special interest in neuromusculoskeletal ultrasound, diagnostic as well as interventions. He's always been a master faculty at various pain medicine and PMR conferences all around the India. So we welcome our two moderators. Now I would like to Dr. Nagma. So please start sharing your screen and please start your first presentation.
So thank you. I thank the Academy of, am I audible?
Yes, sir, you're audible, sir.
Okay, thank you, Academy of Pain Physiatrists for welcoming, for giving the chance to moderate this session. Okay, I thank Yadav sir, Nidesh, Sanjeev, and all pain physicians for giving this opportunity. And I think it's a great platform for the juniors who have learned. And you are bringing some stalwarts or experts in this field. Okay, so we will have more sessions from you, we think, and more chances for the juniors to present their cases and their papers. So I think it's an ideal platform for the physiatrists, so we can learn and we can share our wisdom and knowledge. Thank you once again.
Thank you so
much. Okay, we'll start.
Over to Dr.
Hello, very good morning, everyone. Hello.
Please,
am I audible?
Yes, you're audible.
Yes.
Please continue.
Thank you so much, sir. Good evening, everyone. I'm going to present a journal club on a research.
Hello. Start sharing your screen. You haven't shared your screen.
No, it is visible.
It is visible.
Screen visible.
Acha, visible.
Is it visible?
Yes, it is visible. Please continue.
Okay, sir. Okay, sir. I'm going to present a journal club on a research article done by Shrijith K et al., which was published in BMC Musculoskeletal Disorder on 16th August 2023. The title of the research was, Can ultrasound-guided radiofrequency ablation of genicular nerves of the knee be performed without locating corresponding arterial pulsations? A cadaveric study. So about the journal, the 2022 citation impact factor for this journal is 2.3 for last 2 years and it was 2.8 for last 5 years. And why this article has been chosen? Because it shows an innovative approach which explores a novel technique for radiofrequency ablation for genicular nerves. And the findings of this study helps in improving patient outcomes and give us more efficient method for nerve ablation. And this research is based on a cadaveric model to ensure precision and reliability of the results. So the positive outcome of this study can streamline procedures and can reduce complications during knee interventions. So I believe this article will stimulate a valuable discussion and provide insights into advanced techniques in treatment of musculoskeletal disorders. So as we all know, osteoarthritis knee has an increasing prevalence. And for that, genicular nerve RFA gives us a promising treatment option for knee pain in patients with osteoarthritis. So around in 13 genicular nerve around the knee described, we mainly targeted the superomedial, superolateral and infерomedial genicular nerve. But due to rich vascular anastomosis around knee, it is very difficult to identify arteries corresponding to these genicular nerves, which makes these ultrasound-guided landmarks important. And RFA efficacy not only depends on the disease severity, but also on nerve to radial proximity and electrode width. And for proper nerve ablation, nerve should be at least within the twice of width of electrode. And there has been other studies describing the different courses and targets for genicular nerves. So in this study, it was aimed to evaluate the accuracy of precisely targeting these three genicular nerves by locating bony landmarks under ultrasound in human cadaveric knee specimen. So, what were the landmarks? They took these landmarks based on the study done by Yasser et al. And they found these landmarks 100% accurate in their study. So, for superomedial genicular nerve, it was 1 centimeter anterior to adductor tubercle. For superolateral genicular nerve, it was at the junction of between the lateral epicondyle and shaft of femur, and the target was pressed between the lateral and posterior cortex. And inferior-medial genicular nerve was targeted at the midpoint of deep fibers of MCL insertion and the peak of medial tibial condyle. So, it was an observational descriptive study which was done in 15 human cadaveric knee specimens, and they did ultrasound to identify these landmarks, then inserted the needle, then inject a dye, and then the genicular nerve dissection was done to under microscope. And what were the outcome they assessed? They assessed the staining characteristics and nerve to needle distance of these three nerves. So as I already told, they took 15 cadaveric knee specimens and ultrasound scanning was done to identify these landmarks. And then ultrasound guidance only 22 gauge needle was inserted, and then they injected a dye, and followed by genicular nerve dissection was done under microscope. And then they assessed the staining characteristics and nerve to needle distance, and median of nerve to needle distance was measured and interquartile range was assessed. So as I already described about the landmark, and to target this superomedial genicular nerve, how they located, they kept the linear probe in coronal plane to locate the medial joint line. Then the probe was translated superiorly at the level of adductor tubercle, and at this level probe was rotated to 90 degree in axial view, and 1 centimeter anterior to this adductor tubercle was measured. This was their target entry point of needle, and needle was inserted anterior to posteriorly by in-plane approach, followed by dye injection and dissection, and measurements were taken. And these all steps were followed in both rest other two nerves also. So to target this superolateral genicular nerve, they kept the probe in linear probe in coronal plane at the junction of epicondyle and shaft. And at this level, probe was rotated to 90 degree in axial view, and the target point was junction of lateral cortex and the posterior cortex. And at this junction, needle was inserted, then followed by dissection and measurements were taken. To target inferior-medial genicular nerve, probe was placed at medial joint line in coronal plane, then it was translated inferiorly, and what was the target? Midpoint of deep fibers of MCL and medial tibial condyle. So at this point, probe was rotated to 90 degree, and the most prominent cortex of medial condyle was targeted. So results were demographic details of the cadaver was median length was 162 centimeter, median age was 66 years, and out of 15, 10 were male cadavers. And main outcome was staining characteristics and nerve to needle distance of these genicular nerves. So they found that in all cadavers, all three nerves got stained, and median nerve to needle distance was 1.67 millimeter in superior medial genicular nerve, 3.2 millimeter in superior lateral genicular nerve, 1.8 millimeter in inferior medial genicular nerve. And these all range were within RFA ablation diameter. So as we all know, the size of the lesion produced by RFA needle is directly proportional to width. So for adequate pain relief, needle should be at least within this distance, and which makes it extremely essential to exactly define the target points for these genicular nerves. And in this study, the accuracies of these defined landmarks were 100% in terms of staining, and average nerve to needle distance was within RFA ablation diameter. And on dissection also, it was found that nerve courses were in accordance to these described landmarks. So, with this, they conclude that at these described bony landmarks, ultrasound guided RFA can be done with 100% accuracy. And these landmarks were defined by them, which I already discussed before. So, friends, we can notice in this study was because of rich vascular anastomosis, it is difficult to identify corresponding arteries to nerves. So, these bony landmarks can be used. And since it was a cadaveric study, so visualization of artery is not possible. Still, nerves were targeted accurately. And other strands were that landmarks were confirmed in both coronal and axial view. Needle nerve distance was measured objectively with vernier calipers of high accuracy. Nerve staining was also done, which increases the reliability of the result. Needle was firmly fixed to periosteum, which decreases the movement of needle. And microdissection was done under microscope, which to improve the quality of result. But the limitation was there was small number of cadaveric knee specimens were assessed, and some confounding factors which were not properly addressed are variation in preservation quality like time since death, hydration levels, variation in anatomical landmarks due to differences in length of cadaver, degenerative changes, experience level of investigators in like ultrasound, injection, and dissection also can also affect the outcome of study. And environmental factors like lab settings, temperature, humidity, quality, calibration, and type of ultrasound equipment, these all factors can also affect the outcome of study. So, since it was observational descriptive study without any comparison group and a cadaveric study was done, so efficacy of RFA on pain relief in patient cannot be directly commented. And out of 13 genicular nerves around the knee, only 3 nerves were studied. And this study might be susceptible to investigator bias since both the data collection and analysis was done by the same researcher. And similar studies were done like Fonke et al. They compared the accuracy of classical versus revised technique for genicular nerve block in cadavers, and they found that revised targets are significantly more accurate. And Cillian et al. They compared the effectiveness of traditional genicular nerves alone, that is 3-point block, versus traditional plus 2 additional sensory nerves, which were recurrent fibular and infrapatellar branch of saphenous nerve. So it was 5-point block. So they found that 5-nerve targeted technique is safe and more effective for treating chronic osteoarthritis pain compared to traditional. And these are the other landmarks by ultrasound guidance given in various studies for genicular nerve ablation. And since it was a cadaveric study, so evaluation of study quality was done using Quack scale, and the score came out like 12 out of 13, which is around 92%, which represent a good quality of study. So, but further more studies with new bony landmarks on a greater number of populations are needed to augment the level of evidence. And different studies with comparison between the newer versus conventional one and comparison of different bony landmarks like for superomedial genicular nerve, distal medial femoral condyle or medial tibial condyle proximal end can be assessed, and accuracy of other genicular nerves like recurrent fibular or infrapatellar branch of saphenous nerve can also be assessed. And other studies like comparison between CIAM versus USG guided techniques can be done. So there have been studies with new landmark techniques, but with smaller number of sample size. So additional studies involving larger populations with different techniques, with different comparison groups are required to enhance the level of evidence. And since this new technique has shown a perfect accuracy rate, we are ready to bring it into the fold for treating patients with knee osteoarthritis. Thank you.
Thank you, Dr. Nagma, for excellent presentation. So now over to Dr. Pramanik and Dr. Shrijith sir to discuss and specific questions if you want to discuss on this topic.
Thank you, Nagma, for that nice presentation, and Ranbir also for that eye opener. So we can also adapt that thing. So I have some doubts regarding this. Actually, in a knee pain, when we do a fluoroscopy guided, when you do it, even the locations and all are correct. Sometimes we don't get the exact result. Maybe because the pain generator may be wrong, that we identify as a pain generator may be wrong, or it could be due to the anatomical variations. So maybe your sample size is very small. That may be one reason that you are not finding any anatomical variations in the nerve, because there's a lot of anatomical variations. And that is one thing. Anyway, it's a nice presentation, and I think it's a nice paper. This is a paper by Nitesh and his June, I think. No, that is the paper by Chinju. Is it that paper?
Yes,
Yes,
sir.
sir, same.
Yeah, okay. So it is open for discussion. So any doubts, any clarification, anyone can ask. And Pramanik sir, your comments.
Pramanik sir, your comments, please. Anyone from the audience would like to ask some question regarding this paper or regarding this technique? Okay.
Actually,
So
for OA knee pain,
yes.
is a grade 4 and all. I think genicular nerve sometime may fail because the cause of pain may not be this knee itself. There are maybe other locations or other types of pain when there is that biotensity is lost. So ideal pain generators should be looked upon.
I would like to agree with Dr. Shrijith sir. There are multiple pain generators in the knee, but in cases of the chronic osteoarthritis knee, due to this peripheral sensitization, these nerves get sensitized and they gradually it leads to central sensitization phenomenon, and gradually these are one of the main cause of pain. So if we go for genicular nerve block diagnostic, then if the patient has got more than 70-80% with this blocking these three nerves, then we can go for radio frequency ablation. So this is how we proceed in cases of osteoarthritis cases. So any other questions, or should we
So
proceed?
you should be careful of that nociceptive pain also.
Yes, sir. In this
Also the chronic pain, that biopsychosocial model also should be adopted.
Definitely,
so it should be a holistic approach, and that I think only a physiatrist can do.
Definitely,
every aspect should be looked upon, not just blocking that genicular nerves. So you should treat the patient holistically.
We are targeting only the neuropathic part of the pain, but nociceptive pain and other pain generator should be looked upon. So if there are no other questions, should we proceed to the next presentation by Dr. Saran? Dr. Saran, are you ready? Dr. Saran, are you ready?
Yes, sir, I'm ready.
Okay, so please start sharing your screen and let's start the presentation. The other questions could be taken at the end of your presentation. Please start.
Good evening, one and all. I'm Dr. Saran Kumar, Junior Resident in the Department of PMR AIMS, Jodhpur, presenting before you the article, The Effectiveness of Erector Spinae Plane Block in Patients with Chronic Low Back Pain. This article was published in European Review for Medical and Pharmacological Sciences on 27 January of 2023. The journal has an impact factor of 3.024. Why I selected this article? So we are seeing chronic low back pain patients on a day-to-day basis. At least 10% of the patient are coming to our OPD with a recurrent pain, and it is not relieving despite we did multiple procedures. So this is ESPB is one of the procedure which will provide a good result in low back pain. But there are a lot of controversies existing among the published case reports. Some saying it is effective, some saying it is not that significantly effective. The efficacy rates differs between each article. So this is one article which shows which did a retrospective study on this topic to assess the effectiveness of this ESPB in chronic low back pain. So chronic low back pain is a globally significant health problem which is associated with significant physical, emotional, and financial burdens. We are doing procedures which ranges from caudal, epidural, transforaminal, interlaminar, and if it is reluctant, proceeding to surgeries. And each of the procedure has a different level of evidences in a radicular pain. So we are considering an alternate procedure for effective management of chronic low back pain. So erector spinae plane block, it is considered as an extensive sensory block as it affects either the dorsal or ventral rami or both. So cadaveric study shows most of the time ventral rami are not blocked. It is only the dorsal rami which is blocked by this. So multiple case reports have been published regards with the post-surgical chronic low back pain, or it is used in the post-operative period, immediate post-operative period. So we are this study hereby assess the effectiveness in the chronic low back pain. So before going into the journal, let me explain you a simple anatomy before we proceed on with this journal. So here the dorsal rami once exists, which lies between the transverse process and the anterior facial plane of the erector spinae. So we are targeting this transverse process and separating the anterior facial plane of the erector spinae from the dorsal ramus. Thereby we are blocking the dorsal ramus of the block. But does this block stops there? No, there are multiple cadaveric studies done that shows that it might extend into the paravertebral region and also into the epidural space. Here you can see it is extending into the beneath the psoas major muscle, where the ventral rami can also be blocked. As it progresses and extends upwards, it can go into the paravertebral spaces also. And this is of a thoracic epidural, thoracic erector spinae block, not of the lumbar one actually. So here you can see it is covering the entire epidural space and it is progressing upwards in the paravertebral space also. There was one study which shows that there is a chance that it might block the sympathetic chain anteriorly. So the objective of the actual journal is to assess the analgesic efficacy of the erector spinae plane block in patients with chronic low back pain and radicular symptoms who had a lumbar disc herniation. So it was a retrospective cohort analysis done between January 2019 to 2020 in a hospital in Turkey, and the sample size taken was 96. So the inclusion criteria were patients of 18 to 80 years age with a persistent low back pain for more than 3 months with lumbar disc herniation and radicular symptoms and ASA score of 1 to 3. Exclusion criteria were bleeding diathesis, pregnancy, breastfeeding, anticoagulation medication if they are taking any, and history of drug allergy, especially to opiates or local anesthetics, and infection at the injection site, and refusal to participate in the procedure. So how they did was the patient was placed in a prone position and using a curvilinear probe. It was in a sagittal plane to the transverse process. The muscle was visualized superior to the transverse process. As you are seeing here, we are seeing the erector spinae muscle here and the transverse process here. They approach craniocaudally and they confirm the location with 1 ml of saline, where they can see the split between the transverse process and the erector spinae plane. Once it is observed, they inject a drug which contains a mixture of 10 ml of 0.5% bupivacaine and 40 mg of triamcinolone and 9 ml of normal saline. So the outcomes were measured using visual analog scale, Oswestry Disability Index, patient satisfaction questionnaire, and analgesic consumption during the follow-up period. The follow-up was done at first, 24th, or first, second, third, fourth, 8th, and 24th week. So now they took a population with a mean age group of 52 years and a minimum age group 25 to maximum of 79 years were taken into consideration, and 55 among the population taken were females with the average BMI of or mean BMI of 27.45. And most of the procedure, the PL here mentioned the procedure level, 50% for 50%, the procedure were done at L4 level, and for 27% it was done at L3 level, and for 19% it was done at L5 level. They carried out the procedure unilaterally. They didn't do the procedure bilaterally. It was carried out for 44 patients. It was left side. And as we can see, most of the patients having multiple level disc herniations, 42 of which having L4, L5 to L5S1, and 15 of which having triple level disc herniations and have L3, L4 to L4, L5. So now, coming on to the result published in the study. Before the procedure, the mean visual analog score was 8.4. As we can see, during the first week and of the procedure, it was significantly reduced with a mean value to 1.81. As it progresses second week, there is a slight increases in the visual analog score. As it reaches the third week, end of the third week, they have a significant again increase in the visual analog score. At the end of the follow-up, in a mean of 5.25, there 5.25 was the VAS score, mean VAS score. And Oswestry Disability Index, which correlates with the VAS score, it reduces in the first week and there is some increase in the second week, and at the end of third week, it was significantly increased and it reduces again towards the last. Whereas patient satisfaction questionnaire, in contrary to the persistent elevation of the VAS score, or the patient satisfaction questionnaire is completely, the patient were satisfied. This and it is statistically significant. As we can see, it is a 5-point patient satisfactory questionnaire they used. Initially, it was just 1.13, and during the first week, it was 4, and it is again decreasing at the third week, and again at the end of the 24 weeks, it has a mean value of 3.2. Analgesic consumption. There is no statistically significant decrease in the analgesic consumption, which implies that the patient were taking approximately the same level of analgesics pre-procedure. So the above study shows there is significant improvement in the VAS score at the initial 2 weeks, and after 3 weeks, there is a recurrence in the pain. A recurrence of pain is noted in the test group. Compared with a surgery or epidural injection, though the complication rate is less, we still need to evaluate its efficacy in terms of the chronic pain. The duration of the block may also indicate a variation in the anatomical location. The role of the repeat, can see at the end of the 3 week, the patient is having significant again increase in the pain. So can we repeat the block or not? This again has to be studied. Despite the increase in VAS, the patient was satisfied with the technique in the follow-ups. So they concluded the study that the procedure has a significant effect on the low back pain, but however, after 3 weeks, there are recurrences. So we need further evidence to say that erector spinae block is a successful block in chronic low back pain. So the strength of the study was, it was one of the very first study they conducted, though it is a retrospective study. The study focused clearly on the objective. As we go through CASP's checklist, it is a moderate quality study with 8 out of 13 parameters were satisfied, and no significant complication has been reported among the participants. But the limitations were a retrospective design of the study limits the generalizability of the result. As we can see, they took an age group which is very younger, like 25 years and to 79 years. As age progresses into consideration about the same or the comorbidities of the patient also, the analgesic consumption remains same throughout the study, which also has its own implication on the pain. Chronic pain management always remains multimodal, so there is no information provided regards with whether the patient underwent physical therapies or other modalities like CBT or not. That has not been mentioned. Level of disc herniation, though they described the laterality of the radiation, has not been described whether the patient was having only unilateral radiation or bilateral radiation. That hasn't been described. So they did procedure only on the single side of the patient. No consideration has been taken regards with the comorbidities of the patient or addiction of the patients. So apart from this study, most of the studies were case series or case reports, which is published regards with the erector spinae block. Ji Hee Hong et al., who published a case series with 3 patients, he reported there is a successful relief, and there is Hiramasa et al. Published there's a significant relief in the patient with a failed back surgery syndrome. They repeated the injections thrice during the follow-up period for those patients, and they reported the successful result also. So this is an updated review on possible future directions, which was published by this Alessandro Di Cassi. So they concluded that still we are in need of further evidence to fully understood the role of this block in chronic pain settings. So future directions they give in their study was, we have to assess the efficacy in the chronic pain due to degenerative diseases or spinal stenosis, or investigations of again optimal doses and volume of the drug should also be assessed. This is a cadaveric study which was published in a lumbar erector spinae block to assess the volume, how much volume the might have required. They concluded that 10 ml of the volume may be an alternative to a periradicular injections. Any higher volume may be preferred to epidural block. So in future, we have to establish a standardized protocol and validate its long-term efficacy and safety. Comparative studies we should have done with other interventions such as epidural steroid injections, and incorporation of the erector spinae plane block into multimodal pain management, and maintaining an electronic health record of the patient to assess the long-term outcome of the block also. So take home, yes, there are successful case studies have published in failed back surgery syndrome. Yes, ESPB is a really good procedure. In those cases, we can implement those procedures in patients with failed back surgery syndrome. And persistent low back pain who are reluctant to treat reluctant to other procedures, we can try it on those patients. This procedure was actually introduced in 2016 for treating a chronic thoracic pain, but eventually this procedure is currently employed in the perioperative pace management for perioperative pain relief and all. Regards with chronic pain, still we are requirement of further research and all. They also published evidence with case studies for the erector spinae block in cases with myofascial pain syndromes or even with the posthepatic neuralgias. There are one case study published for erector spinae block in lower limb CRPS, and there were a few case studies published regards with upper limb CRPS. They did a cervical ES erector spinae block also, but it was a continuous infusion they did. Control studies or a prospective studies which was done regards with this topic for assessing the efficacy of the same in the chronic low back pain or any other chronic pain. So thank you.
Thank you, Dr. Saran. So now over to Dr. Shrijith sir and Dr. Pramanik sir.
Thank you, Sharon, for that nice presentation. Actually, I think this is the block every physiatrist can go do in their office. Just very learning curve is also very simple because we just identify the multifidus muscle and just doing the facial process and the multifidus muscle. No,
Yes.
I think it is very easy in the lumbar region. Thoracic also there is no problem, I think, because the rhomboid muscle is there, and behind that there is the actually it is very simple. So I think we can do it as an OP procedures, and a lot of our PGs can take it as a disease also because we are getting a lot of chronic low back pain patients, and we can have a large number of patients also. So I think it is the one who is starting to do these spinal procedures. The first they should do this erector spinae block and all, and I think then they can go for that nerve root blocks and all. I think. Okay, thank you. Then it is open for discussion.
So I would like to summarize the presentation which was given by Dr. Saran. So first of all, this erector spinae plane block, it is a type of regional anesthesia technique. It is a kind of plane block. In this, what we are doing, we are going through the erector spinae muscle, which is the posterior paraspinal muscle, and we are hitting our needle at the anterior end of the transverse process, and there we are giving our cocktail of our medicines, and this medicines goes into at the proximal levels and at the blister levels also. And what it does, the blocks especially the dorsal rami. Now, as we know, the nerve roots which emerge from the neuroforamen divided into dorsal rami, ventral rami. So the drug spread mainly in it. It is volume dependent basically, but basically it blocks the dorsal rami and the supplied structures like the spinal, paraspinal muscles which are present in thoracic and lumbar region. Especially erector spinae and all those muscles. So in the cases where we are seeing the muscle spasm and pain, non-specific mid back pain or the lower back pain, thoracic pain or lumbar pain, then we can utilize this technique. Another what we have, what I've learned from this presentation, that this is a volume dependent technique. What happens if you are giving only 2 to 3 ml of solution, it is goes at a single level only. So the spread is usually 3 to 4 ml per level. So as you are giving around 10 ml of solution, the spread can be up to the 3 to 4 levels also. Also, if you are giving more than 10 ml, then it can spread to the ventral rami also, and it can help in cases where you don't have access to fluoroscopy. You can go for this technique, and the radicular pain can also be treated with this technique. Also, the drug spread also occurs to the sympathetic chain also, so that it can be used for sympathetic mediated pain also. One more thing which I have learned from this presentation is that it lasts from 1 to 4 weeks, 3 to 4 weeks if we say, as told by Dr. Saran. So most of the regional anesthesia practice, they just do the block and they just send the patient. But in case of our physiatry or PMR practice, what we practice the multimodal approach. For example, if I see a cases of a chronic non-specific mechanical low back pain, having this muscle spasm and all those issues, what I will do, if the patient is not responding to the conservative management or to the our medicine treatment, then I will go for this ESP block at, for example, L4 level or L3 level. And then I will subject the patient to the rehabilitation protocol, which will include the stretching of erector spinae muscle, core strengthening exercises, posture. I will explain the posture precautions and lifestyle modifications, and all those things we will do. And if we do all these things together, if we follow this multimodal approach, then definitely the patient will get better in the next 2 to 3 weeks. So if we think that only ESP block will really heal all the pathologies, all those things, this will not happen. It is that this block just helps in relieving the pain so that the patient can practice or follow your rehabilitation protocol or advice, and he can do his exercises and follow the lifestyle precautions. So this is for the pain relief only, but it will not heal the exact biomechanical pathology which is seen in the spine. So I think this is a very useful block. It can be done under ultrasound guidance, which is usually available in most of the departments. So if the fluoroscopy is not available, if you're not expert in fluoroscopy, then you can utilize this block, and you can do it multiple levels accordingly. And if you have to vary the result, then you can vary the volumes. If you want more spread or more craniocaudal spread or more spread to ventral roots or lumbar sphincter block, then you can use the volume from 10-15 ml to 20 ml also. Okay, so this is my submission. So any other comments or any other questions?
And can it be given for this facet pain also? No, it can be
yes,
given for...
yes. The facet pain will definitely be treated with this thing, but because we know that the facet joint is supplied by the medial branch. Okay. Now the one facet joint of the lumbar area, so it is supplied by the facet middle branch of the same level and one above level also. So there's a spread of this drug to the same level also and the proximal level also. So it will definitely help in facetogenic pain. But as I've already said, that you have to treat the biodynamics of the that disease also. So if the facet pain is there, then you have to go for the rehabilitation program also. So any other comments or questions?
Sanjeev,
yeah, please.
Can we have the opinion from the Professor Rajesh Pramanik?
Sir, Rajesh Pramanik, sir, please.
Yeah, actually, it's a nice article, but we are doing this erector spinae block primarily for the axial pain, especially thoracic region and lumbar region. But the block, radicular pain, I think is still controversial. And for the facetal pain, that I don't think that it will really work well, because for the facet, we need to actually block the median branch block or other thing. So erector spinae block, we didn't get so much of result. Otherwise, it's okay because we can do it as an outpatient basis. So in that way, it is easier because it can be done without fluoroscopy guidance also. So we can try, definitely we can try and look for it.
Dr. Sanjeev, have you tried this genicular block in inferior lateral, that is near to the tibia?
Yes, sir. Yes, sir. I have tried go for this inferior lateral genicular nerve. I have done this thing. And I have done this, what we call it, recurrent fibular branch also. And there's infrapatellar branches of saphenous nerve also. So I'm routinely doing this 5-in-1, all the five genicular branches for knee osteoarthritis cases. But what I have said previously, that I usually see the patient should have some neuropathic element of pain. If he's a neuropathic element of pain, then I prefer genicular nerve block or RFA. If the patient has some more of nociceptive pain or muscle pain or some bursitis or all those things, then treating it with different approaches is a better approach.
So in neuropathic pain, that superficial nerves of the femoral nerve can also be blocked, ablated. Superficial nerve of the femoral nerve for the supralateral aspect of the knee.
Yes, sir. Yes.
That also can be ablated.
But it is difficult to find that nerve.
No, actually, it lies above that sartorius muscle, no. That
yes.
Small nerves, that superficial branch of the femoral nerves, just above the sartorius muscle, you can see smaller nerves. So that is also a cause for the neuropathic pain of the knee.
Yes, sir. So,
any other
question, please?
I have 2 questions, sir.
Yes.
First question is, when to start the rehabilitation protocol after this procedure, and what exercises you prescribe after this ESP block, and
ESP.
should it be given bilaterally?
Okay. So first of all, rehabilitation protocol, it can be started immediately after that. There is no specific contraindication of. You can start stretching exercise. You should start first of all stretching exercise. Along with that, then you can go for other strengthening exercises. For core strengthening exercise, you can go for that. Regarding bilateral, usually bilateral is not recommended because it will reduce the strength of the spine. The patient will have difficulty in getting up from the sitting to changing position, sitting to stand position. Initially, it may reduce some. If you are giving high volume, then it may reduce some uh, uh, pain also, and reduce some strength also, may cause. If you are giving some on higher concentration or higher volume, you usually it should be avoided by giving bilaterally. You should give unilaterally only. And what was your third question?
Thank you, sir. I have only 2 questions. You answer.
Okay.
Thank you, sir.
So first thing, basically, I think there is one question: is there an effect on progression of after the ablation?
Over to Dr. Rajesh Pramanik, sir. This question, I think he's asking, Dr. Sandeep is asking that whether the knee osteoarthritis progresses after doing this genicular nerve RFA.
Yeah, the thing is that it's a palliative approach, isn't it? Genicular nerve RFA. So we are not actually targeting the disease process. So if it is generally we do it in advanced state. So if it is not that much advanced, then the internal process will go on. So disease progression will go on, but patient will not perceive the pain. So that is the main issue. So we are not in a curative state. We are going for a palliative approach. So yes, the disease will progress.
Actually, that is the role of other modalities and exercises. Start an intense rehabilitation program. Otherwise, the patient will have the biomechanics will be altered, and the patient will have severe deformities. So that is it is just not a block. You should start other things also to prevent the progression, like weight reduction, the improving the biomechanics, and other strengthening of the proximal muscles. Everything should be done in a package. Otherwise, there is no.
Yeah, and each and everything is revolving around the integrative approach for pain management, not just to focus on the blocks. First and foremost, on the clinical examination, identification of exact pain generator in the osteoarthritis knee. Usually, what happened whenever the patient comes for OPD, we directly think of osteoarthritis knee. Any patient come with the knee pain is osteoarthritis knee. This is already set up in our mind. But many times there are so many pain generator structures that we should to train our residents for clinical examination, better identification of pain generator, and then plan for the integrative program, not only for the doing the genicular blocks. Okay, and but we should think of the integrative approach, including the rehab program, what type of orthotic management we should do, how we can improve the quality of life, how we can save the energy consumption of patients. So that should be targeted for the proper management of osteoarthritis of knee.
So that is the role of the diagnostic ultrasound of the knee. So you can diagnose gout and pseudo gout and all. Sometimes the pain may be due to this arthritis and nothing with the osteoarthritis, maybe having other causes for the knee pain, such as bursas and this gout and pseudo gout or other causes. The diagnostic element is also very important that you should focus on.
Yes, sir.
And then you identify
one more important
and treat it.
Yeah. Many times we get the tendinosis of posterior aspect of the knee. Commonly the tendinosis of semitendinosis, semimembranosis, which is more common for the posterior medial pain.
Okay, yes.
Dr. Raj Kumar is asking that total knee arthroplasty should be the treatment of choice, but if patient is not willing or having multiple comorbidities, and then only we should go for RFA for advanced cases. So he's making this comment. So definitely it is there. The patient should be offered knee replacement or arthroplasty. But if the patient is not willing or some have medical comorbidities like heart diseases or hypothyroidism or some surgical contraindications, then we can go for RFA for pain management only. We will not, as Dr. Pramanik has said, that is for palliative care. And Dr. Chandrapreet ma'am is asking, any ASP block, any experience in spinal metastasis or local vertebral body tumor? So I don't think there will be any effect on these two pathologies. So the ESP block will have effect only on the what we can see the structures which are supplied mainly by the dorsal vertebra, that are the muscles or paraspinal areas only. So if you can go for that.
Sorry to interrupt this about the ma'am has asked about the erector spinae block experience in the spinal metastasis. For this, depending on the metastasis, we can have the vertebroplasty, put the cement in the vertebra. And for the second option, there are again radiofrequency ablation. Usually the radiology people do, and they put the needle for the bony ablation. For bony tumor ablation, these are the two options. One is the intravertebral radiofrequency ablation for the vertebral body tumor, or we can have the gray rami communicum ablation. Or if there is too much of collapse of vertebra, if the posterior border is intact, then we can have the vertebroplasty for the spinal metastasis. But I don't think that erector spinae block will be helpful in these two cases.
It will not be helpful, definitely.
What if the tumor is spread into the muscles like a GCT tumor, which is already operated, and there's a recurrence? Then can we give, can we not give?
Pardon, ma'am?
Local tumor like a giant cell tumor of the spine operated, but there's a recurrence, local spread of the tumor. So, and the patient is complaining of pain in that area of the spine only, where the tumor is there. So, anybody tried this ESP block in that? What kind of pain will it can be given to that patient? GCT of the spine, giant cell tumor of the spine.
Dr. Nitesh, would you like to answer that question?
I'm not getting the ma'am's question with you. Hello?
Hello, sorry. There's too much explanation.
Hello?
Hello, can you hear me?
Yes.
Supposing there's a giant cell tumor of the spine, there's a recurrence already operated. So
okay.
that may have spread to the erector spinae muscle with that as well.
In that case, basically but primary actually lesion in the vertebra. So you should target the vertebra.
That's already operated.
Along with we can go for the erector spinae block if it is spread out already in the erector spinae muscle. I don't think that will be much of. In that cases, we can plan for the intrathecal opioids. That can be the better option, I think, for the pain management. For the palliation purpose only.
Okay.
There is one more question by Dr. Jishnu. Is there any significance of adductor muscle strengthening in management of osteoarthritis knee? So over to Dr. Pramanik, sir.
Yes, for the adductor muscle strengthening, it's not really significant in osteoarthritis management. because primarily we get weakness of the BMO. So strengthening of BMO is more important. Adductor is not that much important, I think.
So any other questions?
One question is of Rajkumar sir. This is called as arterial embolization. Yes, this is usually practiced by the radiologist. There are the particles basically they put into the genicular arteries.
May I say something?
Yes, sir. Yes, sir. Please.
Some of the interventional cardiologists, they started this genicular artery embolization in advanced way, but it's actually not that much cost effective, and
it is expensive.
It's not exciting really. They started it initially, but nowadays they are not doing. So this probably it's not that much effective.
Yes. So I think we have come to the end of our Journal Club activity today. So I would like to thank our moderators, Dr. Rajesh Pramanik sir and Dr. Shrijith sir.
Hello.
Yadav sir is,
I think
Yadav sir is there. Please.
Yadav sir is saying something.
Yes, sir. Please.
Yeah.
No, Sanjeev, I mean, that's fine. Like I was hearing throughout the discussion, that was great, really great. But we need to understand about the basics also that probably we are forgetting about. No, because the one thing is the muscle standing about the cordyceps, like which Pramanik was talking about the BMO. Second thing, the core muscle standing is really plays a very great role in treating the osteoarthritis knee. And other thing is like, like the weight and then, the modification of the footwear. And at the same time, the bone density management. Because these are the co-factors which is also contributing to generating the osteoarthritis knee. So we need to go for the holistic approach rather than to just going through, genicular nerve block, or ablation, whatever, or maybe intra-articular injections. So we have to look into that aspects also before we really conclude that like what intervention we need to do in these kind of conditions. So that way, like we have to give a thought on that as well. So whenever we want to treat the osteoarthritis knee, then probably we have to look at the holistic approach. Yes, I mean, that's my viewpoint.
Definitely, sir. Sir, we as physiatrists, we should look at all the aspects of the disease and its treatment, and we should follow our rehabilitation program, as Dr. Yadav sir has said. These intervention procedures are mainly used specifically when the pain is not getting control, even with all types of approaches we are using. But if the pain is not under control, then we can use these modalities. Agreed, sir?
Yeah, absolutely right.
Yes, sir. Yes, sir. So
we should not forget about the basics of the treatment.
Sir,
rather to just go on the intervention straight away.
Yes, sir.
Yes, sir.
I mean, that's my viewpoint.
Definitely, sir. So we are coming to the end. Thank you, sir. Thank you, sir. So we are coming to the end of our today's activity. So I would like to thank Dr. Pramanik sir and Dr. Shrijith sir to grace us with their presence in our Journal Club activity. And I would like to thank you all the participants, our president, Dr. Yadav sir, for their presence. So good night all, and we will be meeting on the next activity. Will be, I think.
Sanjeev, can I add one thing?
Yes, please.
If you permit me.
Yes, please, sir.
No, all these speakers, they were great. Like the way the things were carried forward by Rambir. He put in so many input. That's really commendable.
Yes, yes, sir.
I congratulate all the speakers. They also contributed a lot into this discussion. And all the participants also, I thank them. Like it was a really great event for tonight. Thank you so much and good night.
Good night, sir. So I will thank Dr. Saran and Dr. Nagma for excellent presentation. So our next activity will be on the 8th of June, that is subgluteal syndrome, and we will be meeting on that day. Okay. Thank you all.
Thank you.
Thank you.
Good night.
Thank you.